This is John Queenan. I'm doing a micro video presentation on how to appeal denied claims by third-party payers. Denied claims are some of the more frustrating things we face as clinicians in this field. I think invariably this happens to some of the cases we care most about, a long and complicated surgery or an ART case. In many instances, these are denied claims that happen in the setting where we obtain prior authorization, and so it's additionally frustrating from the amount of effort that we've put in ahead of time to assure that the claim will go through smoothly. So I'd like to talk about a rationale that you should follow that will help you order the process and obtain the best route for success. When you're notified that a claim has been denied, the first step you should take is to make sure you are right in the original instance. Ask yourself these simple and basic questions. What's normally included and excluded for the code that's being billed? In the case of surgery, there are often multiple procedures being billed, and so was the correct CPT modifier used? Also look at the diagnostic code. Did the diagnostic code match the service provided? And also, specific to the field of infertility, there's often contractual restriction by payers. Sometimes infertility coverage is limited by third-party payer contracts. The next thing to think about is to not take this personally. When a claim is denied, it was not something that was read by an individual who potentially had it out for you. In fact, the claim wasn't likely read by a human being at all. Our claims are processed, converted to digitized numbers so that a diagnosis claim is placed into the ICD-10 system, submitted as a number. Procedures are translated into CPT codes, submitted as numbers. These numbers are input into claims processing software. And these software are very intricate. They will look at upwards of 300 exclusion criteria and verify whether the claim should be approved. Some of the marketing of claims software is to actually tout how good the software is at excluding services based on vigorous review of some of the things that you see listed here on this slide. I'm going to go through actual examples today, and I want to talk about one problem that I think is common to all of us, and that's the process of inappropriate bundling by third-party payers. So I'm going to take this example. You perform a reversal of a prior tubal ligation and you receive prior authorization from the patient's insurer. Now that might not have been the best choice since insurers may not cover reversal of tubal ligation in all 50 states, but let's just use this as a teaching point so the actual nature of the surgery is not important. At the time of surgery, you discover a subserosal myoma of significant size and you decide to remove it. In fact, it took considerable time and effort and added a great deal of time to an already long case. When you submit your claim for the tubal reversal, you also list that you performed an abdominal myomectomy and you report it under the appropriate modifier. And then later you're told by the payer that they will only pay for the reversal and your claim for the modifier has been denied. You're quite certain you submitted this appropriately and you think about the appeal process. How should you approach this? Before you begin, first of all, you want to make sure you're right, and an invaluable resource in doing this is to have the ACOG coding manual. And the manual is quite important because it contains the following information. So let's take our example of a tubal reversal. You can see the CPT code 58750, and when you open the manual and go to this page, you'll see that ACOG has provided you the included services and the excluded services. So there is a code for chromopertubation, but that's an included service, so that is always typically performed with a tubal reversal and so not billable separately. But if you look under excluded services, you see examples of specific other things that you might encounter intraoperatively, and these are not part of the global service, therefore they're excluded. So if these are performed, they are reported separately. So you can go down this list and see if you encounter an intra-abdominal or retroperitoneal tumor or cyst or endometriomas, those are reportable separately. If you decided you needed to do diagnostic laparoscopy to assess tubal length before proceeding with, say, abdominal tubal anastomosis, that's reportable separately. Third on our list here is abdominal myomectomy. So this is clear documentation that if you did have to perform this procedure in addition to tubal anastomosis, it's separately identifiable and reported, eligible for additional reimbursement. So you go back and verify that you have the correct documentation in your medical record to support the claim. Does the op report reflect the fact that you did an abdominal myomectomy? Perhaps your op note was dictated by a resident and they neglected to include that. So verify that you have the correct documentation to support your claim. Once that's done, you want to begin the appeals process. You begin with polite negotiation. It's very important to document every person you talk to, the date and time. Initial negotiations will probably take place with your staff. They'll contact the claims department and try to obtain the reason for a denial. When you receive your denial in writing, it's usually under an EOB form, an explanation of benefits, and unfortunately it too is probably reported as a number with very minimal explanation, a number leading to a explanation at the bottom of the page with very few specifics. When speaking with claims personnel, you want to make sure you're all using the same language, so use these specific CPT codes and ICD-9 codes when communicating. Your staff will try to verify the completeness or the accuracy of the claim, and oftentimes the next step will simply be to resubmit the claim with appropriate supporting documentation. So in the case of inappropriate bundling in the surgery that we're talking about, you'd submit the op report. You could submit it with a cover letter of explanation, and then following that, the billing staff should follow up, contact the claims department or the insurer, and find out what is the status, document each time who you spoke to and when. If billing staff does not obtain a satisfactory resolution, then this is the time when the MD needs to get involved. From this point onward, I would suggest you conduct all communication in writing and you address all communication directly to the medical director of your plan. A question that we receive on the coding committee quite commonly is, do you have a form letter for us that we could use when writing about denials due to inappropriate bundling? And we do. So I'll help you with that in this next slide. So this is a form letter that you could use. In the above referenced claim, you have bundled, and you would insert the procedure, say tubal anastomosis, and insert the procedure abdominal myomectomy together, and denied reimbursement for the latter. These are two separate and distinct procedures. The Manual of Correct Procedural Coding for 2016 by the American College of Obstetrics and Gynecology states that abdominal myomectomy is excluded from the global service and always reported separately. See attachment. And then for your attachment, you would put a photocopy of that page that I showed you that shows the included and excluded services, and you probably take a highlighter and draw their eyes to the fact that abdominal myomectomy is always reported separately. You can close with this final sentence if you followed all of these steps appropriately. The coding that has been submitted is in accordance with the guidelines of ASRM, ACOG, and the AMA, and I think that packs a pretty powerful punch. If you encounter inappropriate bundling of laboratory services in ART cycles, then there's another document I want to call your attention to. So the coding committee has, every 4 years, updated a practice committee bulletin for correct coding of laboratory procedures in ART cycles. Just like the ACOG manual, we go through each individual laboratory procedure and talk about what are the included and excluded services. This has been published in Fertility and Sterility. It's on the ACOG website under the practice guidelines as well as on the coding section. But you would refer to this document and once again probably put a photocopy of this document and highlight the specific nomenclature that supports your case if you encounter inappropriate bundling of laboratory services. Let's say you still have not received a satisfactory resolution. At this point, you would ask for a manual review by a board-certified physician in your same specialty. They are legally obligated to provide this for you, so don't be shy in asking for that. At this point also, you may want to be cautioned to never change the medical record to add any information that you think is going to support your claim. You make addendums or notes that are appropriately dated, but never go back and change original documentation. Possibly you may want to involve state or local medical societies if you still have not received appropriate resolution. And there are also instances where there is a pattern of denials by a specific insurer or third-party payer. And when this happens over and over again and you're certain that it's happening unjustifiably, at that point you want to notify your state insurance commissioner, and you also should mention this to ACOG. ACOG has a form for reporting third-party payer complaints. On the staff at ACOG, there are legal support and lobbyists on Capitol Hill, and they are positioned to provide some extra weight to the third-party payers who are exhibiting inappropriate behavior. This is the contact information at ACOG, the Department of Health Economics, their fax and phone number, and again, you may want to also consider it when it reaches this point of sending a copy of all of your correspondence to the state insurance commissioner. A final question that I think comes up in all of our minds is, do I actually want to spend the time to fight this fight? There's a significant amount of cost versus potentially relatively small reimbursement that's at stake. Fighting a denied claim is going to involve staff time, physician time, stamina, and so I think this is part of the reason why many times we just let this go, leaving money on the table. I'd encourage you to follow these steps. They're relatively simple, they're relatively easy. The time course is fairly drawn out, and so you do have to have patience. But in the end, there's significant gratification if you win your appeal, and this should go a long way to help stopping this behavior from that same third-party payer in the future. That's the end of this presentation. I want to thank you for your attention and thank ASRM for bringing this to everyone's attention.